People sometimes say that in this lifetime, the only things we can be certain of are death and taxes. But while most of us prepare for taxes, people are often unprepared for death. The point at which many confront their mortality is in the doctor's office or hospital. 80% of Americans die in a hospital or long-term care facility. Prior to antibiotics and other medical advances, people often died quickly, usually of infectious disease or accidents. Today, the vast majority of Americans have a more protracted experience with death. Families in the terminally ill, whether young or old, have a broad range of physical, practical, and spiritual needs. Hospice is a special form of care designed to provide comfort and support to patients and their families when curative treatments no longer work. It's built on compassion. There's a special emphasis on controlling a patient's pain and discomfort. But whether a patient is at a hospice, in a hospital, or at home, the spiritual, emotional, and social impact of end-of-life care are critical. What is hospice care? How does it integrate with other types of health care? And how can you handle the momentous events that often accompany the death of a loved one? Hi, I'm Rich Creek, host of On the Horizon, and with me in the studio today are Donna Faribault, nurse, Hospice of Howard County, Jack Dunleavy, chaplain, Howard County General Hospital, and Susan Duggan, Thai Sophia Institute. Welcome to On the Horizon.
Thank you.
Thank you very much.
Oh, I suppose we can call this show today Living with Dying. And some might say, is this a topic we should talk about, death and dying? Susan, what's your take on that?
My take is that we can't afford not to talk about. We were talking before that we've all received the diagnosis. It's just a question of when. I don't think it's an easy topic to talk about, but often I find that there's great relief when we break open the conversation.
So that families, in the course of their family life, they should feel open to talking about death.
Well, last year we did a program on aging at Thai Sophia, and we asked a lot of the seniors in the group some of their concerns. And one of their main concerns was having the conversation with their own children, that they were afraid to bring up the topic. And I often hear in the treatment room that people with aging parents are often afraid to have the conversation. So I think anything that opens up the dialogue can just add to a little more peacefulness.
Okay. Jack, at the hospital, is it your sense that at the point that someone is experiencing a very severe medical condition that they have talked about this beforehand, or is that sometimes the first time that families get around to discussing these very challenging issues?
Often it's the first time they discuss it. And I would say initially there's such a shock by the patient that it takes them a day or so to really get into a conversation with families. And I found by officiating at several funerals, the best gift that you can give to your loved ones is to talk about how you want your funeral, what you want in the last weeks, months that you have. It's a precious time, and it's a gift that we can give and are given to each other.
Yes, and going down our table, Donna, with Hospice of Howard County, of course, you have the patient and you have the family. Would you agree with what Jack's saying there?
Oh, absolutely, and with Susan too. And especially in Columbia, it's a very young community, and we have, death doesn't occur when you're in your 80s or 90s or even up to 100 now. We have many people in their 20s and 30s and 40s who are facing the end of their life due to cancer or maybe some other illness. And so like you said, every family is going to be affected by this. It's nothing that we've ever been trained for. These aren't conversations that they give you in college and say, well, down the road you're going to talk about this. We don't get any preparation, and many families, especially ones that we grew up in, never dealt with it. They were always afraid to. So I think it's really a wonderful teaching experience, a wonderful learning life experience for all families, especially when there's young children. It shows them how to deal with adversity and with a terrible situation. It shows them that it's not going to be the end of the world. Yes, it's going to be very sad and we're going to cry, but we're all going to be in this together. And so I think it's a wonderful community and family experience.
Okay, well, Donna, let's stick with you for the moment. I think hospice care is probably a concept that many in the audience don't know much about. They've certainly heard about it. But why don't you tell us, if you will, what is hospice care?
Hospice is actually a philosophy more than it is a place or a type of medical service. We believe that in helping people through the end stages of their life, and it could be through cancer, heart disease, kidney disease, it could be any number of things. We even get a lot of people, older people with dementia and Alzheimer's disease. So there's no one specific category that we fall into. But it's a way that we deal with people, help them keep comfortable, help manage their symptoms, and help the family walk through the whole experience. Like I said, we don't get any training, and so most people don't know what to do. And usually the comment we get afterwards is, I don't know why I didn't get you sooner, and I don't know how I could have done it without you. So it's very valuable. It's a whole team process. We have a chaplain, we have social workers, we have wonderful volunteers. Howard County has some of the best volunteers around. We have nurses, and we have a nurse manager, and we have a doctor from who works with, he's a geriatrician, and he's also a hospice certified, and so he works with us and he guides us, and we go to him for information. We work together as a team. We have a conference every week so we can discuss everybody. In case we're stuck with something somewhere, we can talk to a colleague and to our doctor, and he can give us advice and tell us where to go. But there's a lot of help available out there.
Okay. I wanted to get back, Jack, to some of the comments you made in terms of, let's say we have a woman who's given notice that she's got stage 3 breast cancer.
Yes.
Is that the point that the chaplains program would make contact with her? How is it that you would interact with that patient at Howard County General?
Ideally, we would like to visit every patient every day so that we've already got a rapport established with the patient if they were to be told that their condition was terminal. When they are told, we would still visit. We would continue on, encourage them to talk on not only to us, but talk to their spouse, to their family. I've had several cases where the patient was afraid to talk to their spouse because they might upset them. The spouse was afraid to talk to the patient because they might upset them. And to get the two of them talking together was a gift for both of them. So communication, I think, is essential. We also, by being present as a chaplaincy program or the pastoral care program in the hospital, bring forth out of the patient their religion, their God, so they can use that as a resource during this traumatic time in their life.
So what I'm hearing is, at that moment of recognition of that severe, let's say, cancer, the patient has a time of fear, which is natural,
Yes.
and really has to kind of master what it is that the physical condition is. But there's this whole other set of factors of the family
Yes.
and communications. And I see you nodding yes.
Yes.
Have you had some experience around that?
Yeah, and I think that's the place. I think that we all probably have some agreement on that there can be physical pain, but I would think the emotional or spiritual pain can be as much, if not more. So sometimes the talking can break that open, and we can identify some of the places of suffering, and sometimes it's fear of leaving the loved ones behind, a fear of being a burden to family members, just the difficulty of letting go of loved ones and family and pets, a favorite car, just all the stuff of life. Sometimes anger shows up, anger at family members, unresolved hurts, chance to do some work of forgiving family members or
Wonderful opportunity.
And what I'm hearing you say is that those very things that you just mentioned, Susan, are opportunities at that point to maybe get some resolution and the enormous uplift for all concerned that can happen. And I'm assuming it could be a very simple communication.
I think that's what's been so gratifying, astounding, awe-inspiring, and sometimes what brings me to my knees is also watching that people might be dying, but also healing
Yes.
can happen.
Absolutely.
That dying might happen, cure in the traditional sense of an illness might not happen, but people can die well. And their families sometimes say, what a beautiful experience it was. I don't want to diminish the pain and the sadness. And there's another side that sometimes shows up.
Now, Susan, Donna, mentioned pain in sadness, pain in the sense of emotional pain. But is it a given that there would be physical pain at the end of life?
Not necessarily. Unfortunately, many people believe that with cancer you're going to be in excruciating pain. And that's really only true in about 30% of the cases, and it really may not even be that much. Some people don't have any pain at all. I could have 5 people with lung cancer, and they're all going to have 5 totally different symptoms, and they may not have any trouble breathing. So it manifests itself in many different ways. But we work very hard to control the physical pain. And that's why we have the team that we do to work with the emotional pain too. And you know, they're well trained and they're wonderful people. We also have, I forgot to mention before, bereavement services, and we stay with the family for a year afterwards. And they have wonderful groups that meet. They have widow groups, they have groups for children, they have groups for young parents and for parental loss, but people of young children who have passed away too. And we try to make contact as soon as possible. Sometimes people are maybe have a high need, and so we'll have them call the next day. And very often we'll have the bereavement counselor meet the people beforehand so they can start working right away if we see there's going to be a lot of difficulty with them coping with their grief.
And for you just mentioned grief, bereavement really is the process of dealing with that grief.
That's correct, yes.
And sometimes we're not talking about an extended, protracted period, but the sudden loss of somebody.
Yes.
And that must be a whole other experience. Jack, could you comment on that when someone goes into the hospital perhaps, and 80% of Americans die in a long-term care facility or a hospital, but they don't come out, and it wasn't expected. How do you cope with something like that?
Again, we still visit the patient and are with the patient until the time of death. If it's a sudden, unexpected death, the ministry really moves over to the family and tries to give support to the family, comfort, whatever they would like, whatever we can do to help them, we provide that.
Now, let's go back to that woman who's told she has stage 3 breast cancer. A woman has a 13-year-old son.
Mm-hmm.
How does she deal with that? How do you deal with children when you have this reality enter into someone's life? Hopefully after the fear factor is diminished, some on the part of the patient.
Right.
What comes to your mind on that?
Communication, being honest and open about it, talking to the 13-year-old, talking to the mother, asking various questions, being honest with the answers. I think it would be inappropriate not to tell a 13-year-old that they have this 2 or 3 or 4 week window, or maybe months, that they can be together. So I really support communication openly.
And if that child says, Mom, are you going to die?
I think we spend too much time denying death. I think we need to be honest and say, yes, it looks like I am going to die.
And we're all going to. We're all going to die at some point.
Yeah,
like
we've all
Susan
said that. Susan
suggested.
said that earlier. We're all dying.
Right.
Just some have the privilege to know that it's within a short period of time.
Yes.
The rest of us don't know.
All right. Donna, my perception always has been that hospice takes over when you're no longer in a curative care capacity. You're really taking the step of looking more at comfort, quality of life, family. Are there people who, let's say, go into a residential hospice like yours, but still elect to have, let's say, aggressive therapy?
It depends on their age, because a lot of younger people who have regular insurance can still pursue treatment. Usually it's for palliation as opposed to aggressive. But if people come to me and say, I'm still looking for a cure, I back them. I don't take away their hope and say, oh no, that's not going to happen. We meet people wherever they are, whether they're in total denial and they can't deal with it, we just walk it with them and wait till they can deal with it and help them through that. But somebody who is on Medicare, if they're going to seek active treatment, then they wouldn't be referred to hospice for care. They would still seek the treatment because Medicare won't pay for both. You can only do one or the other. But certainly if somebody comes to us and maybe need radiation because of a new pain, their cancer has spread somewhere and they need that, we cover that and we pay for that. We do anything that's necessary to help with their pain and their comfort. Sometimes that involves procedures, maybe to have fluid removed from the abdomen or from the lungs, or even a minor surgical procedure if need be. But whatever it takes to make them more comfortable, we're going to do. And people, like I said, we don't take away their hope. I think hospice, a lot of people believe that when you come to hospice, it means you're giving up. And I believe that we don't give up on you, and we want to make you live as long as possible. We want to help you to live comfortably and enjoy as much as you can. Like Jack said, it's a wonderful opportunity. It's an opportunity for healing with families who have some estrangement. It's an opportunity for them to come back together and to have a lot of healing there. So hope takes on many forms. We're living right until the last second that we die, and I think we're more about living than we are about dying. We want to make that a good experience.
And that goes back to what you said, Susan. In a way, I guess this counterpoint of impending death really puts light on life. Can you maybe comment a little bit about that?
There's an African man, an African teacher by the name of Maldomus Somé, and he tells a story that in our 40s, death comes like a mask, and it looks us straight in the face, scares the bejesus out of most of us. So the task is to take this, put it on your shoulder, and carry this mask like a companion that informs. And while we're talking about terminally ill people, I want to say, can we use the lessons that we've all learned to start earlier on? Can we have the conversations with our children while we're well? Can we have the conversations with our spouses? There's a wonderful document that we carry at the Institute in the bookstore, and it's called 5 Wishes. It's a beautiful document to open up a conversation because it talks about, how do I want to be cared for? It's not too early to fill this out, no matter what the age. And if we're a little afraid to have the conversation, sometimes it can open it up. Like, I want this song played at a memorial service, or say these things about me after I'm gone.
Okay, well, I like that response quite a lot. Jack, Susan mentioned an African tradition.
Yes.
And people have different faith traditions. And here in Howard County, we have a remarkably diverse population. And I'm assuming that given these different faith traditions and philosophies of life, that aspect of diversity may make it somewhat complicated for you to go in. How do you respond to the different cultures and backgrounds that we have here in Howard County?
Thank you for asking that question, because I think it's really important and vital. As a hospital chaplain, I represent all faiths and all beliefs. We do not try to convert anybody. We do not preach. We do not push any religion or any church. I like to use the expression, we wrap ourselves in our own belief to find God in our center so that we can go and be with patients to help them to find God in their center.
What about Korean, Hispanic faiths, or Asian types of traditions? When you look at the statistics, we've got a remarkably diverse population.
Right. We do.
I imagine even translation is a major hurdle in terms of end of life. So do I see you going like this? Is that something you've grappled with, Donna?
Well, yeah, we have many people who haven't spoken a word of English. We've had Koreans, we've had Russians, we've had Chinese. I took care of a lovely woman that Susan knows who is Chinese, and they were Buddhist. What I do when I come into a home like that, I ask them what their beliefs are and how I can help them, or where the lines should be drawn, what I can do and what I can't do, what you want me to do, what you don't want me to do, and find out what their comfort level is. So I don't want to step on anybody's toes, and I don't want to offend their religion in any way. So we always try to find out. There's I think Jewish Family Services works with us, and so we make referrals there whenever the people request it. We always offer it. And we try to seek out whatever in the community we can to get them help. We've gotten Muslims. Trying to think, we had a gentleman from Pakistan, and there was a mosque down in D.C. that we put them in contact with and just helped them make the funeral plans. And because the family didn't know, he was a very young man and he had young children, and he wasn't prepared for this. And so a lot of people don't know there's usually a community of people from their own country for many of the immigrants that are here. So we try to put them in contact with them, but we try to work with them wherever they are. There's many services available around here, and that's just a matter of finding them and helping them be in contact with them.
The word that's coming into my mind is team. because what you're all
Absolutely.
saying is that maybe starting with a family, that although unwanted, not desired in any way, when these contingencies fall into our lives, being surrounded by people, if this is what the individual wants, can be one of the most almost life-giving
Oh, absolutely.
opportunities that can happen. Have you all seen examples like that, where you find that maybe for the first time in someone's life, they're really getting it to that brother who they didn't speak to, and so on, and maybe we have to flip-flop some in terms of really seeing this untoward event turned around and turned into as much of a positive as possible.
Yes. While you both were talking, I was thinking it takes a village to raise a child.
Right.
I think it takes a village to care for our loved ones. I was talking with my mother about this, and I remember my father talking about it when my father was still alive, the memory of wakes being held in the living room.
Right.
And people probably had more familiarity with how to care for a dying person, and maybe people had more familiarity with what dying looked like. So I think it takes a village now to help one another. I remember my first experience, my grandfather's death, when I was 5, and he was whisked out of the house, and I didn't know what happened to him. And the fears that I had around that for the next year, I was scared to death that something would happen like that to one of my parents. I didn't see a dead person until I was 15 or 16. So I think there's an awful lot of that. It's in the shadows. Can we help one another to bring it more out into the forefront? Can we talk to one another about these things? Can we build a community for one another to bring this more out into the open?
Very important words there, Susan. On the other side of this, there are individuals like yourselves. Jack, I think it's been 18, 19 years.
Yes.
You worked at Howard County General in this area as a
Right.
chaplain.
Correct.
You've been in hospice and oncology treatment situations. And people out there may wonder, how is it that day after day you and volunteers are able to cope with people dying? Comment on that, if you will.
I found that I had to have my own emotional support base around me as well. A group that I could go to and talk about, not about the confidentiality of the patient, but about my own emotions, how I'm coping with the death of an infant or whatever the situation is. For the 18 years I've been a part of the hospital, 17 of them I volunteered, and I just kept coming back because I got so much out of being with patients. And I learned how to support myself and how to let go, because you have to learn how to let go at the end of the day, and that's not easy.
Thank you for sharing that.
Yeah.
And Donna, it probably requires a certain type of volunteer. There are probably people who are not, for various reasons, suited for this. How is it that you identify volunteers, and how many volunteers do you have? Let's start with that, with hospice. And
That figure I don't know.
Okay.
Offhand, I don't know. We have quite a few and we've had some wonderful ones. Howard County has been voted best volunteer organization in the state many times by the governor. But they go through a training. They go through a rather intense training. And I think somebody who has just suffered a loss, we'll work with them for a while, but we don't let them become volunteers for at least a year. We want them to be able to work with their own grief without jumping into another situation. But they're very well trained. They go through an intense training, and I think that probably this goes for the staff as well as volunteers. Certain people we're attracted to certain places, and we tend to draw very caring people who are involved and just are very sensitive and caring just about anybody they take care of. I believe all relationships have value, and when you think about it, they're all going to end at some point, whether through death or divorce or you just fade away or whatever. But these relationships that we have with people are just, like Jack said, they give us so much. I know going into it that this is going to be a short-term relationship, but it's still I don't not let myself get involved, or I don't not become a part of that, because there's just so much value in it, and there's so much that they give us. And it's just, to me, it's worth it.
I'm thinking here that the quantity of time's down, but the quality may go way, way, way
Oh,
up.
absolutely.
And you know, I don't want to let this conversation pass without saying a few words about some of these cases that we've seen. Terry Schiavo, not the specifics of it, but I want to say, have you comment on such things as advanced directives, you know, health proxies, namely communicating what your desires are if the worst happens and you're uncommunicative. Talk some about the importance of that, Jack.
It's absolutely essential, I think, for every person to have advanced directives in place. It was such a gift when I sit with a family that's agonizing over what to do next, when you can ask, well, what did their loved one want? What did your father, mother, brother, sister want? And they can say, oh, they were very clear. They didn't want this, or they did want this or that. That you have something to grow on, something to build on, so that the family can make a decision. And it's always an emotional decision, but most families are able to work through that, and that is such a gift to have those in place ahead of time.
Donna, can you also comment on that? It's a terribly important issue.
Well, it is very important because when people come to us, most of them are usually able to talk, although sometimes they're not able to. And we have to know that we're doing what they want, because you know, if they want food or if they want IVs or this or that, then we will allow that. We will just say, well, you know, you'll have to do this to get that. But we support people no matter where they are. But it's, I mean, it was Terry Schiavo has proven that it's absolutely necessary in today's world, no matter what age you are. And I try to have that discussion with my children all the time. But we meet people, sometimes we'll have people that don't want to sign that or don't have one, or they don't want to sign a DNR form, which is the Do Not Resuscitate form. But we walk with people wherever they are, and we try to support them. And then, you know, they may reach a point and say, well, this is going to happen. You know, if you really still want to go to the emergency room, this is what they're going to do, but this is what we'll do if you don't want to go there. And we usually, by walking day by day with them through this journey, they're able to say, no, you're right, we don't want to do that anymore.
And I'm hopeful that the doctor also is not just left there at the hospital or in his or her office. The doctor probably also is involved in those discussions, even
Yeah,
at the
absolutely.
point that the curative regimen is departed from. Is that correct?
Yeah, they are very involved.
Okay.
And if they're having the discussion to refer them to hospice, then they've already started that conversation. So,
Okay.
yeah.
So the other general principle here seems to be honesty throughout. That
Absolutely.
You really try to understand what the desires are of the individual, and that's shared with the family if conditions permit that. That's the optimal. I'm sort of thinking, you know, death's not the opposite of life; it's the opposite of birth, and that we have an opportunity here to really have some more life, a higher quotient of life, if you will.
Absolutely.
And I think that this has really been an enlightening conversation. I appreciate all of you coming in today, and I want to say to have all of our audience think about this, because certainly there's no more important topic. I'm Rich Krieg, host of On the Horizon, and I want to thank our guests, Donna and Jack and Susan.
Thank you.
We'll see you next
Thank
time.
you.